This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. It's an honor and privilege to introduce our speaker this morning, Dr. Marlene Williams. She's an associate professor of medicine at Johns Hopkins University and currently serves as the clinical director of cardiology at the Johns Hopkins Bayview Medical Center. She did her undergraduate in biochemistry at McGill University in Montreal, Canada, received her medical degree from Columbia in New York, and completed her internship fellowship at Johns Hopkins with additional training at Mount Sinai Hospital. She has truly been a lead. She is a leader at Hopkins in education, service, and research, and her research focuses on platelet physiology, particularly as it relates to acute coronary syndrome and the genetics of platelet physiology. She has received funding both from the NIH and the American Heart Association to study platelet physiology. And on a personal note, she and I met a couple of years back at the AAMC Mid-Career Women's Conference. And since then, we've been career buddies, as we like to call ourselves, always checking in and trying to make sure we don't fall down the path of mid-career donut hole. But she's been a colleague, a national champion, and a mentor. We served together on the American College of Cardiology Young Scholars Workforce. And she also serves on the board of directors of the Association of Black Cardiologists. So please give a warm virtual welcome to Dr. Marlene Williams. Thank you.
Thank you so much, Dr. Ogeni. Yeah, you are the one that keeps me bolstered up most of the time. So thank you so much. I appreciate this invitation. I think in order to leave some time for perhaps some discussions at the end, we'll just get started. So the topic of my talk today is personalized antiplatelet therapy. And in this season of the large changing landscape of antiplatelet therapy, I think it's important for us to consider how do we personalize antiplatelet therapy for our patients that are presenting primarily with acute coronary syndrome and those who require percutaneous coronary intervention. This is my first slide. There we go. This is my disclosure slide. And whenever you think about personalized antiplatelet therapy, we should always be considering this issue of precision medicine. And what is precision medicine? I look at it as it's the right treatment to the right patient at the right time. And I include this image to demonstrate that there are multiple pathways that can activate platelets. And because there are multiple pathways that can activate platelets, we now have at our fingertips many antiplatelet medications, which actually allows us to be able to treat patients differently according to the pathway that we're trying to focus on. And because we have a lot of choice in that matter, this leads to the ability to personalize antiplatelet therapy. So our objectives for today is, I know, I'm preaching to the choir, so this is cardiology, grand rounds, and I'm sure many that are very familiar with the guidelines. But again, I just want to kind of focus on this issue of personalizing antiplatelet therapy. So we're going to review some current guidelines for dual antiplatelet therapy, explore some antiplatelet escalation and de-escalation options, all in the name of personalizing therapy, explore evidence for personalized platelet testing. So what we think of the traditional personalized antiplatelet assessment, And then finally, familiarize ourselves with risk scores for thrombosis and bleeding, because ultimately, that's actually what we're focusing on. And that's actually what we're trying to do. We're trying to minimize thrombosis in the same, as well as minimize bleeding risk. So I'm sure at Emory, as it is at Johns Hopkins, we usually start grand rounds focusing around a patient and patient presentation. So this is a patient that was presented, admitted to our hospital several months ago. This is a 69-year-old woman with a history of hypertension, diabetes, hyperlipidemia. She was an active smoker, and she presented with complaining of substernal chest pain, which was off and on for the past couple of days. She had reported that it was worse with certain exertion. She was hypertensive on presentation to the emergency department. Her pulse was 88, normal respiratory rate. On physical exam, she was in some mild distress. She had had an episode of this discomfort before coming in. Her lungs were clear, however, and cardiac exam was regular rhythm. She had a benign systolic murmur. She had no evidence of peripheral edema, no evidence of arousal on lung exam, and she had warm extremities. Her initial EKG demonstrated 2 millimeter ST depression in 1 in AVL and V4 through V6. Her initial blood work demonstrated a creatinine of 1.4, a normal potassium. Her hemoglobin was 11, and her troponin I, and I will digress for a second. We were using traditional troponin, not high sensitivity troponin, but I want to thank your Dr. Amit Goyal, who helped us, Goyal, who helped us transition to high sensitivity troponin here at Johns Hopkins Bayview. His teaching and his guidance was really excellent and helped us to transition quite well. So thank you, Dr. Goyal. So her initial troponin was 0.77 and it escalated to a maximum of 22 when she presented. In the emergency department, she was initially treated with sublingual nitroglycerin. With some improvement of her chest discomfort, she was loaded on aspirin, started on unfractionated heparin, and loaded on ticagrelor and treated with metoprolol. And at that point, she was stabilized, admitted initially to the floor, stabilized, and then the following day, she was taken to the cardiac catheterization. It was a radial case. She had on cath, she had a normal left main. She had a 40% LAD lesion, a 90% osteal circumflex lesion, and an 80% RCA lesion. She had a drug-eluting stent placed to her circumflex, and then an 80% with a 90% stenosis, and drug-eluting stent placed to a 80% mid-RCA lesion. And she was continued on aspirin and ticagrelor, went back to her room, was doing very well. On the third day was scheduled to be discharged. So a day later, however, her hemoglobin dropped to 6.5. And later on, as we were working up with this anemia, she had an episode of melanoma. And so the question was, what do we do at this point? So as I said, we'll go over the DAPT guidelines. So this is an image that demonstrates both ACC, AHA, and European guidelines DAPT recommendation. And as we can see in patients, they're very similar between the American and European guidelines with this minimal differences. But as we can see, if we have a patient who has stable coronary artery disease and no high bleeding risk, the recommendation, class 1 recommendations, is 6 months of dual antiplatelet therapy, and perhaps longer. Again, if there's no high bleeding risk, data from the DAPT studies recommends perhaps or would suggest that 30 months of dual antiplatelet therapy is reasonable. similar in European guidelines. However, if you do have high bleeding risk, the recommendations is not quite as strong, but a class 2B recommendation for 3 months of dual antiplatelet therapy from the ACC/AHA, and European guidelines give a slightly stronger recommendation, a 2A recommendation for 3 months of dual antiplatelet therapy, obviously to mitigate the bleeding risk. Similarly, in acute coronary syndrome, it's similar, a recommendation. ACC/AHA and European guidelines suggest 12 months of dual antiplatelet therapy. There's evidence for prolonged dual antiplatelet therapy without patients with high bleeding risk from the Pegasus trial, demonstrating that you can go on to more than 30 months, about 33 or so months, both in the European and American guidelines. And certainly if you have a high bleeding risk, shorter than that, so 6 months of dual antiplatelet therapy, and a little bit difference in terms of the level of recommendation. In the ACC/AHA guidelines, they recommend at least class 1, you can use clopidogrel, prasugrel, or ticagrelor. They do recommend ticagrelor over clopidogrel as a class 2A recommendation based on a lot of the clinical trials. So, so the DAPT guidelines basically says if you have stable coronary artery disease, it should be 6 months of dual antiplatelet therapy. If acute coronary syndrome, it's 12 months of dual antiplatelet therapy. If you have high ischemic risk, you should consider to be treated longer, and high bleeding risk to be considered shorter. But many times we are given this curveball, whether it's thrombotic or bleeding. Oftentimes it's a bleeding issue, and that's where personalized therapy and considering what we should do for these patients are important. And the whole focus of determining what's best, what's the right treatment for the right person at the right time is balancing bleeding and thrombosis in patients with acute coronary syndrome. We want to minimize bleeding and also obviously minimize thrombosis. But we have to consider what's the highest risk of thrombosis. So we know that there are temporal changes in patients with ischemic and bleeding risk after percutaneous coronary intervention. The earliest thrombotic risk is generally as they're presenting. So they come in with an acute coronary syndrome. They have literally thrombus within their coronary vessels. So there's localized thrombus there. And we can either remove the thrombus with intervention or, and many times place a balloon. And the balloon itself can cause endothelial injury, again, leading to additional thrombosis. We place a stent in the endothelium as well within that vessel. And then the stent itself, made from stainless steel and then more updated materials, which is a foreign material, can lead to localized thrombosis as well. And we know from many of the clinical trials that most of the potent benefit of P2Y12 occurs early and upfront. There are benefits longer term too, but the most of the benefit is from immediately after they present with their acute coronary syndrome. So we're often addressing this issue of what occurs if there is bleeding. How can we or should we de-escalate to mitigate this bleeding in the context of someone who's coming in with thrombosis? So some of the options for de-escalation and personalization includes, should we stop aspirin? Should we stop a P2Y12? Should we reduce P2Y12 dosing? Should we decrease to the least potent P2Y12 agent? And then what I would consider is what we generally consider as personalized medicine is testing platelet function and testing genotyping. But I want to argue with, well, not argue, but I want to convince you hopefully that all of these options are really options for personalized care. And so I think as we are practicing now, we're really truly practicing personalized care, because when it comes down to the patient level, these are all things that we can do to, again, mitigate both thrombosis and bleeding. So I'll just go over some of the options we have for stopping aspirin and whether or not there are clinical trials for that. Well, it turns out there are several clinical trials. This is a meta-analysis of clinical trials that was published in 2020. that demonstrated, this was a meta-analysis that looked at over 32,000 patients, stopping aspirin between 1 to 3 months after PCI, and generally with placement of drug-eluting stent. And what they found was overall, there's a significant 40% reduction in major bleeding if you stop aspirin within 1 to 3 months, without a concomitant increase in major adverse cardiac events. And this has been very helpful in terms of showing helpful for direction of care. And so the clinical implications of stopping aspirin early is that it does reduce bleeding. There's no increase in major adverse cardiac events. However, we have to consider the population. This is a meta-analysis of 5 different clinical trials, so they all had slightly different entry criteria. However, the overall makeup of these patients, 44% of them were stable coronary artery disease, so not 100% acute coronary syndrome. And 84% of these patients were on more potent antiplatelets, so prasugrel or ticagrelor. So we have to consider that in that context. So how about, can we stop P2I12 after PCI or after PCI to determine mitigate, again, as I said, bleeding risk? So there have been several trials, but I'm not going to go over all of them, but here's 3 of some of the representative trials. They were all open label trials, so we take it with a grain of salt. There's a DAPT-STEMI trial, and the DAPT-STEMI trial was not a large trial. It was a trial of about 800 to 900 patients, and they stopped their P2I12 at 6 months in, and they had a combined endpoint, both ischemic and bleeding. And it was found to be non-inferior. However, it was not powered to look at the ischemic endpoint, and so it was informative, but not quite as informative as we would like. The REDUCE study was a slightly larger study of patients with acute coronary syndrome. They stopped P2I12 at 3 months. Similarly, they had a combined endpoint of both ischemic and bleeding, and it was found to be non-inferior. However, there was an increased risk of MI and stent thrombosis, and so consequently, there was some concern there. And finally, the SMART-DATE trial was powered to be able to look at patients who presented with acute coronary syndrome. They stopped P2I12 at 6 months, and they had both an ischemic endpoint, death, MI, and stroke, which was found to be non-inferior, but no significant reduction in bleeding. And so, consequently, they concluded probably the clinical implications are there's no indication for just planned early de-escalation just because, but we can potentially consider this in patients who are at high bleeding risk. So what about reducing P2I12 dosing? There are also clinical trials looking at that as well. And one in particular I want to mention was the host-reduced polytechnic ACS trial, kind of like a long mouthful, but this study I think was important. So this was a study that looked at patients who presented with acute coronary syndrome. It was a study done in 35 centers, but all in South Korea. And they were all on aspirin and prasugrel for 10 milligrams for 1 month. And then after that month, half of them were reduced to 5 milligrams of prasugrel along with aspirin. And the other half was the traditional dosing of 10 milligrams with aspirin. And they were followed for 12 months. And what they found was when they looked at the cumulative incidence of both ischemic and thrombotic, they found that there was a significant, in those groups that were de-escalated, there was a significant reduction of the cumulative incidence, primarily driven by a reduction in bleeding without an increase in major adverse cardiac event. And it had met its criteria for non-inferiority. And so they concluded that reduced dose prasugrel with low dose aspirin is non-inferior to a regular dose. But there are some caveats with this study. Caveats is that one of them is that the mean weight of these patients were lower than what we would generally see in perhaps a North American population. So it was about 72 kilograms. And as I mentioned to you, was an all Asian population. However, I think, they certainly had a significant absolute risk reduction, about 2.9%, and their number needed to treat was 34. So it may spawn further research and similar trials looking at this in a more heterogeneous population, I would say. So what about options for decreasing the potency of P2Y12 agents? Well, it turns out there are some trials for this that has looked at this. So the TOPIC trial was not a large trial. Again, this was an open label randomized trial in patients who presented after acute coronary syndrome. They were all on ticagrelor or prasugrel, and then half of this, I think it was about 650 patients, of these patients were downgraded to clopidogrel. And what they found was that there's a significant reduction in bleeding. The cumulative incidence, both primarily bleeding. They weren't powered to be able to look at ischemic changes. And so they thought that, there's some safety in terms of reducing bleeding when you downgrade from a more potent P2Y12 agent. But again, as I said, it was not powered to be able to look at ischemic risk significantly. The tropical ACS was a slightly different study, and this was looking at platelet function. So these are patients, about 2,000 or so patients that presented with an acute coronary syndrome. And it was a little different in that they were treated with prasugrel or ticagrelor for 1 week. And then after that 1 week after coming in for an acute coronary syndrome and having their PCI, they then were downgraded to clopidogrel and had platelet function testing. With the platelet function testing, if they responded appropriately to clopidogrel, well, they continued on clopidogrel. If they did not, they were again changed back to prasugrel and ticagrelor. And what did they find? So this is in the guided de-escalation group. It met a non-inferiority criteria. So the proportion of patients who had a combined ischemic endpoint and bleeding endpoint was 7.3 in the de-escalated percent in the escalated group versus 9% with a hazard ratio of 0.81. And most of the benefit was significant, was reduction in bleeding, although it didn't quite reach statistical significance in this group. The drawback, however, with the tropical ACS is that they had to come in 1 week after their acute coronary syndrome and de-escalate. And so that's, they had to come in, get their platelet function tested, and that's a little obviously unusual for patients who are presenting with acute coronary syndrome. And so I think we have to consider that in the context of practical care for patients with acute coronary syndrome. Are you going to bring them, are you going to de-escalate 1 week later and then another week later bring them in for platelet function testing? The next study was the popular genetics trial. And the popular genetics trial, this is a result from what they did was genotype guide these patients. So what they did was, in half of the patients that are on ticagrelor or prasugrel, and the other half were genotyped, if they had a loss of function allele, and we'll talk about that in just in a little bit. If they did not respond appropriately to clopidogrel, or they had this particular genotype that leads patients not to respond to clopidogrel, they were then escalated back up to ticagrelor. And if they did not have this loss of genotype guided group, loss of function allele, they were maintained on clopidogrel. And what we found was a significant reduction in bleeding in the genotype guided group. So there, again, there's a signal for safety if you're de-escalating from ticagrelor to clopidogrel using genotype guided. And then finally, the popular age study said, well, look, because age is one risk factor for bleeding in patients who present with acute coronary syndrome, why don't we enroll patients who are over the age of 70 and have them de-escalate from prasugrel to ticagrelor and determine if there is a net benefit. And in the popular age study, it was about 1,000 patients who after acute coronary syndrome, half of them were randomized to clopidogrel and the other half stayed on prasugrel and ticagrelor. And what they found was they had both a net, when they looked at ischemic events, there was no significant increase in ischemic events, but significant reduction in bleeding complication. Again, demonstrating a signal for safety when using platelet function, particularly, or platelet, not using platelet function, but reducing from a more potent P2I12 to a less potent P2I12 without an increase in thrombotic events. We have other options as well in terms of personalization for antiplatelet therapy. Well, we can what about reducing aspirin dosing? And this is a study, is a proof of concept study. I really like this. So this was, will lower dose aspirin be effective in ACS? Willow ACS. I think that's like, I like that name, Willow ACS. Anyhow, so this is a study that looked at 20 patients. So again, it's proof of concept pharmacodynamic study that looked at 20 patients who had been within 30 days to 10 months of an acute coronary syndrome, who were all on aspirin and ticagrelor, aspirin 75 milligrams and ticagrelor 90. This was a study in the UK. And what they had was they tested them for response to aspirin. So they did platelet aggregation to arachidonic acid. They measured thromboxane production to make sure that they're appropriately responding to aspirin. And then they measured bleeding time. All of this is laboratory testing in these patients. And what they had is one group of them. So remember, this is 20 patients, so it's 10 in each group. 10 of those patients were taking 20 milligrams of aspirin along with ticagrelor, and the other 10 were taking 75 milligrams of aspirin. And what they did was they trained these patients to be, I think, at-home chemists. So they gave them lyophilized aspirin along with a solute. I'm assuming that it's either probably water or some sort of normal saline, and had them mix them up, probably at their breakfast table, I'm not sure, in the bathroom, not sure. But they did this themselves and gave them a syringe. And for those patients who are on 20 milligrams of aspirin, they had them suck out 20 mLs, throw away the rest of the stuff that they put in their coffee cup, I guess, I don't know, and have them drink this 20 milligrams and do that twice a day. And so the group of patients that were then on the 75 milligrams, they had them do 100 milligrams of lyophilized aspirin along with 100 mLs of some solvent. Again, I think it's water. And had them take 25 mLs out, throw away the syringe, and then drink the rest. So without putting their coffee cup in the garbage. So, so they had them do that. And after 14 days, they measured, as I said, platelet aggregation to arachidonic acid, thromboxane production, as well as bleeding time. And then they served as their own controls. So 14 days later, they switched. They did the opposite of what the other group was doing. And then they went back to 75 milligrams. And here's what they found. They found, compared to aspirin 75 milligrams once a day, aspirin 20 milligrams twice a day provided consistent inhibition of platelet thromboxane release and aggregation and improved post-dose bleeding time in ticagrelor-treated ACS patients. I thought it was a wonderful proof of concept study. This is really exciting. I like that. In the UK, they're really, cutting edge. So perhaps we will see more of this. I'm imagining the, bedside breakfast preparation of aspirin will probably change, but I think it's interesting nonetheless. And then what else options do we have? So we can certainly test platelet function and test genotyping. And as I said, traditionally, this is what is considered to be the traditional antiplatelet test and precision medicine when looking at personalized care. We have multiple instruments that are available that can be both bedside as well as, within the laboratory to use to assess both platelet function and platelet genotype. So the instrumentation, at least in order to test this, is certainly here. But, despite the fact that there have been some clinical trials and we certainly have the instrumentation, what do the guidelines tell us in terms of platelet function testing? So both ACC, AHA, and European guidelines really do not recommend routine platelet function testing or genetic testing to guide P2Y12 therapy. And the reason is because they say so far they haven't routinely seen benefit in, as I said, to do this on an everyday, every patient basis. However, there is some support for the use of platelet function testing to look at patient adherence to antiplatelet therapy. I don't know if many of you may have been familiar with, many years ago, there was this whole series of lines of research looking at aspirin resistance. And it turns out that some of this, at least, was not because there is some odd response to aspirin, but because there was patient adherence. So patients weren't taking the medication that they were supposed to be taking. So certainly if you're able to assess platelet function, that may be helpful to determine if patients are taking their medications. And then finally, perhaps there is a role for platelet function testing in the timing of cardiac surgery following withdrawal of P2Y12 therapy. I know here at Hopkins, many times we will load patients on P2Y12, take them up to the cath lab, and we see that there's triple vessel disease or left main or something that we would proceed to surgery for, but we've already loaded them on a P2Y12. And the question is, what's the, how long do we wait before we proceed with cardiac surgery? And certainly there is a potential role for platelet function testing to determine when we can go ahead safely instead of, just waiting standard length of time in terms of days. And because a lot of small trials and large trials have generated a lot of interest in this, there's now, an expert consensus statement on platelet function and genotype testing in patients in order to guide P2Y12 receptor. And this came out in 2019. And basically what they recommend is, we need to have validated assays with validated cutoffs, particularly as it relates to platelet function. There are multiple ways that you can assess platelet function. And a lot of these assays people are using different, or a lot of clinical trials are using different cutoffs. But in order for it to be useful and practical, we really have to have validated cutoffs. It should be point of care assays that we can use, so that we want to be able to test someone immediately and have some sort of response and data that we can act on immediately, instead of sending something out and waiting 5 to 10 5 days or so for the response. That's really not very practical. They do still recommend that routine platelet function testing is not recommended. However, in specific clinical scenarios, it might be very helpful. And also it may be useful after percutaneous coronary intervention to determine, bleeding risk and ischemic risk, and certainly potentially helpful in the use when we de-escalate from more potent antiplatelet therapy to less potent antiplatelet therapy, to make sure that we have the response that we want to have. And I really like their central illustration here, where it tells us, after your percutaneous coronary intervention, you take into consideration the clinical and procedural characteristics. There's obviously very significant procedural characteristics, which would make us think that the thrombotic risk is much higher than the bleeding risk, and that we should consider, potentially escalating dual antiplatelet therapy based on a high thrombotic risk. And then similarly, clinical and procedural characteristics and socioeconomic factors. We know that, at least now with ticagrelor, the cost is an issue in many patients. And so we have to consider that, again, that's a realistic issue. And so they recommend that whether platelet function testing and genotyping in both of these scenarios may help to inform us in terms of what P2Y12 agent we should be giving. And again, when we're testing platelet function, part of that is also assessing genotype of response, genotype of CYP2C19. And again, as I know I'm preaching to the choir, so we know that clopidogrel is a prodrug, thienopyridine, and as a prodrug, which means that it needs to be metabolized before that it can be active. However, 85% of clopidogrel is converted to an inactive form, so you only have 15% of it, which is metabolized by the cytochrome P450 system, of which there are multiple enzymes, particularly CYP2C19, which has garnered a lot of the interest in terms of response. And if patients have a loss of function allele, in the CYP2C19 gene, they do not respond appropriately to clopidogrel. Prasugrel is also a prodrug, and it is metabolized, but 100% of it is metabolized to its active form. And so consequently, we don't have these issues with prasugrel, and certainly not ticagrelor either. So the CYP2C19, as I said, has been extensively evaluated. And there's a study, a consortium of about 7 or so US institutions, probably larger than that now, the IGNITE network, that has looked at the clinical consequences of abnormal genotype in patients after percutaneous coronary intervention, and have found that some alleles of importance are the STAR2 and STAR3 alleles, which leads to a loss of function, meaning patients do not respond appropriately to clopidogrel. And then there's the STAR17 allele, which leads to a gain of function and can be often implicated in the setting of increased bleeding in patients who are on clopidogrel. And further, there's more information that comes out from the Clinical Pharmacogenetics Implementation Consortium. And this consortium has looked at correlating genotype with phenotype. And they've actually demonstrated 5 different phenotypes in response to clopidogrel. So we have the ultra metabolizers, the rapid metabolizers, and the normal metabolizers. And they also give a prevalence of these different phenotypes within the different communities. And also, they also have clopidogrel implications. So ultra metabolizers may respond or may have normal or even increased antiplatelet response to clopidogrel. Similarly to rapid metabolizers, and normal metabolizers have regular response or appropriate response to clopidogrel. And they also go one step further in giving therapeutic recommendations. So in the ultra metabolizers, rapid metabolizers, and normal metabolizers, they recommend to use clopidogrel at the recommended doses. However, the group that is of concerns are the intermediate metabolizers and the poor metabolizers that actually have diminished antiplatelet response to clopidogrel. And they've also documented increased major adverse cardiac event after percutaneous coronary intervention. And they suggest using alternative antiplatelet therapy, whether it's prasugrel or ticagrelor, if there are no contraindications. So it's very helpful. This field is moving quickly, and again, helping us to personalize our P2Y12 therapy. And I mentioned this study before, but just want to just focus on this because this was an important study. So the popular genetic study is a study that was about 2,000 patients, and it tested the theory of de-escalation. So if we are on a more potent P2Y12 agent, how does de-escalating help us based on genetic findings? So again, as I told you, the carriers, the STAR2 and STAR3 loss of function allele, half of these patients were genotyped for the loss of function allele. They found approximately 39% of these patients had the loss of function allele, so they escalated them back up to ticagrelor and prasugrel. And what they found was there was less bleeding in the clopidogrel group with a hazard ratio of 0.78. And there was no difference in major adverse cardiac event, and it reached the criteria for non-inferiority. So again, when we actually genotype guide these patients and demonstrate that they have this loss of function allele, they're kept on more potent antiplatelet therapy. But if they do not, and they're reduced to clopidogrel, there's a significant reduction in bleeding without an increase in major adverse cardiac events, demonstrating a benefit of this. However, the Taylor PCI study was a different study. They looked at escalating care. So what they did was, in these patients, about 5,000 patients, 80% of them or so had acute coronary syndrome, and they genotyped them. And in those patients who were carriers of this loss of function allele, they escalated them up to ticagrelor. And then looked at what's the incidence of major adverse cardiac event in the genotype guided or the bleeding. And they didn't find any significant difference between the bleeding or the combined endpoint of thrombosis in this group. And so what they demonstrated is probably escalating just for the case of escalation. It's a little bit more nuanced, and they really didn't find a difference, but de-escalation is where they found a lot of the benefit for. So of course, there have been many of these clinical trials that have been published. And so this is data from a meta-analysis and a systematic review of both platelet functional testing as well as genotype testing. And they demonstrated that in patients undergoing percutaneous coronary intervention, if you use whether you use platelet function testing or genetic testing, it significantly improves major adverse cardiac events with a significant reduction in minor bleeding. And I'm sorry, I just covered this over. I just wanted to show that here the benefits were when you use it for guided escalation with a reduction in cardiovascular death and myocardial infarction, a reduction in minor bleeding, but the major bleeding crossed the line of unity. And so really demonstrate, I think, some benefit of using platelet genotyping to inform clinical P2I12 use. There was an associated editorial, and really the similar things as what the expert consensus statement had said in terms of platelet function. You really need to have standardized testing, kind of puts you in the mind of, INR. So now we use this international ratio that everyone is speaking the same language. So similarly, we have to be able to do that when we're doing both platelet function testing and genotyping. You have to be able to have rapid CYP2C19 assays. Again, we can't wait 5 days for this. This is something that we should be able to turn around within an hour. There is more consideration of comorbidities when you're doing guided testing. For example, if we're in the Taylor PCI study, perhaps just escalating just to escalate, say, is not, that's not necessarily a method you may want to use. And there are patients you have to look at comorbidities such as diabetes and renal function that correlates to thrombosis and may more point to other things rather than antiplatelet therapy. And then certainly the timing of testing is extremely important, both platelet functional testing. Certainly we know genotyping, that the timing perhaps is less important, but certainly platelet functional testing, the timing has to be done appropriately right to assess, again, mitigating the issues of both thrombosis and bleeding. And so we are often asked when we're looking at this topic is how can we predict or bleeding? So there are a couple of tests, there are a couple of methods that we can use to precisely assess what our bleeding risk is. And the precise DAPT is a score using hemoglobin, white blood cell, age, and creatinine and previous bleeding. Plug that information in to be able to help us to determine a risk of bleeding. The C statistics for the precise DAPT score is about 0.6 to 0.75. So not perfect, but not bad either in determining, and it has been validated in several different cohorts. And so, if you're able to get a precise DAP score and it's greater than 25, it suggests a high bleeding risk and may suggest to us as providers to perhaps shorten or think about using a less potent P2Y12 agent. Similarly, we have the DAP score, again, that has been validated as well, and can be used in patients. Remembering the DAP score was demonstrated after 12 months of dual antiplatelet therapy in patients who were doing well, so no bleeding and no thrombotic issues, not immediately. So we have to keep that in context if we're going to use the DAP score up front. It came from the data after patients were on it for 12 months. But suffice to say that a score of greater than 2 using the DAP score variables is greater than 2 suggests a longer DAPT may be better, so a higher thrombotic risk, and a score of less than 2 suggesting a higher bleeding risk, and perhaps shortening DAPT will be helpful. And then there's another score, which is the Paris risk score, which is not used as much, but I really like this score because it has both the bleeding risk as well as thrombotic risk when we are addressing our patients. And it's helpful to assess this, and also shows that there's overlap in terms of bleeding, both bleeding and thrombotic risk. So getting back to our patients, what is the optimal antiplatelet strategy in patients who present with GI bleeding? And so that was the question that we had in our patients who had this acute coronary syndrome and then recurrent and then bleeding issue. And this was a nice, gave us a nice algorithm of what to consider in patients who who present with GI bleeding. So we know that if you come with GI bleeding, they recommend that if there's a recent myocardial infarction and if you've had percutaneous coronary intervention with drug-eluting stent less than 12 months, well, you might want to consider resuming the DAP and consider shortening the DAP, and certainly adding a PPI to these patients. If it's more than 12 months, then consider clopidogrel monotherapy. Similarly, they gave recommendations in terms of stable ischemic heart disease. If there's no prior PCI or PCI with drug-eluting stents, consider clopidogrel monotherapy. And then if you've had stable coronary disease, but you've had less than 6 months of dual antiplatelet therapy, perhaps resuming the DAPT with aspirin and clopidogrel, which is really the P2Y12 of choice in stable coronary artery disease. And then they consider shortening it from, as I said, some of the clinical trials that looked at 1 to 3 months, and definitely adding PPI. What's nice is that they do recommend using a risk score to predict bleeding and thrombosis. So what did we do for our patient? So we transfused her. We actually, the intern and perhaps the resident went back and spoke to her, and she was saying, well, I was having this back pain, this scapular pain, and I thought it was my arthritis pain. It was in my left shoulder. Probably it was her ischemia. And she was taking non-steroidals, but it was over the counter, so she didn't think remember to tell us about that. And we think that was probably what her risk was. Nonetheless, we did, because she had such a significant reduction in her hemoglobin. We took her, she had an EGD, she had evidence of gastritis, but no active bleeding. We started her on a PPI. We switched her from ticagrelor to clopidogrel because it was so significant. We monitored her hemoglobin. Her echo demonstrated just some infralateral hypokinesis, and she was discharged home on on day number 6 after her presentation. But here are some questions that came up. Should we genotype her now? Because now she's no longer on ticagrelor, she's on clopidogrel. Should we assess platelet response to clopidogrel? Again, it's a less potent antiplatelet, and she just came in with an acute coronary syndrome. And although she has acute coronary syndrome, should we shorten her P2Y12 DAP therapy to 6 months versus 12 months, as has been recommended in both the guidelines, at least recommended not at class 1, but a class 2 recommendation. And also, this has been looked at in the European literature as well, And what they've summarized is that, we use our clinical judgment, but within that clinical judgment, we should be considering PCI complexity, risk scores, and they do mention genetic testing and platelet function testing could be part of this risk stratification. And then at some point we decide, is this a high bleeding risk? If it's high bleeding risk, we should shorten or de-escalate antithrombotic risk. And if it's a low bleeding risk and high ischemic risk, we should extend antithrombotic risk. And both of that, taking that all into consideration to have the net clinical benefit for patient-tailored therapy. So I think it's time to personalize antiplatelet therapy. I think we are doing that already. And that we're doing that by assessing thrombotic risk. We're doing that by assessing bleeding risk. We also looking at antiplatelet potency is important in individualizing this treatment for patients. And we are making decisions in terms of shortened versus lengthened course based on this whole balance of thrombotic and bleeding risk. Certainly, there's definitely the role for PPIs. And then certainly platelet function testing, I think it's still ripe for further use of platelet function testing, both functional as well as genotyping testing, given the resources and the information that we have at present that will further personalize antiplatelet therapy. And I thank you for your attention.
Thank you, Dr. Williams. That was a very nice review of where we currently are with antiplatelet therapy. We'll now open this up for questions from our audience and discussion. Type your questions in the chat or unmute, and I'll go ahead and ask a question while we're waiting. So, the story always gets more complicated when we have to add anticoagulation for AFib. And, when we're testing from what I understand right now, we're testing for, Plavix insensitivity. So we do the clopidogrel testing, but then what about prasugrel and ticagrelor? They're antiplatelets also. So is there testing that you're aware of that's coming down the pipeline for those?
Right. Yeah, so they are the more potent antiplatelet therapies that are out there. So there's a cartridge for clopidogrel. You're absolutely right, the Verify Now and some others, specifically the Verify Now. But when we're doing traditional platelet functional testing, you can test for any antiplatelet. If you do, for example, platelet aggregation, which is in a laboratory, it's a little, more cumbersome. And that's why they're saying there are other assays out there. In particular, there's something called the TEG success, which really tells you what's happening with your level of thrombosis and your level of bleeding. And so you can be on any P2I12 agent and it can assess that. There are some things coming down the pike in that particular assay as well, looking at more specific direct oral anticoagulant and also just overall platelet function.
Great. What are your thoughts about patients who have MINOCA? So, they come in, they have ACS, but it's troponin elevation, but no obstructive disease, and they don't get a stent. Are you doing 12 months of dual antiplatelets in that population?
Yeah, so that's a good question. So I've, looked at the data. I have to say that I have to follow the data with that. And I know that the patients with MINOCA actually often have an increased incidence, sometimes like they might have another event and another event. And whether there's something on an endothelial function wise that is creating this localized thrombus is possibly. I basically look at what's the extent of troponin elevation. I look at, for any other causes, whether there is, coronary spasm and make my decision. But I will say for the most part, most of those patients, I am using aspirin and clopidogrel, perhaps not the more potent P2I12, because there's many of those, obviously we don't stent. And I'm doing that, for a period of time, whether it's, 6 to 12 months, I decide based on, bleeding risks and stuff. But I am using aspirin and clopidogrel in those patients with Minocta.
Great, thank you.
Okay.
Dr. Smith?
Yeah, so I just have a question about how you operationalize new knowledge. So about 4 years ago, I asked our interventional cardiologist, is it better to do things the best way or the same way? And they all said it was best to do it the best way. And then I gave them a scenario of a patient who had had a PCI, and they gave me 4 different answers of the best way to treat that based upon the information coming out. And they have the same physician assistant who works with them and discharges patients from the hospital.
Mm-hmm.
So as new things come out, how are y'all approaching this in your center, or is it just purely physician specific based upon what a patient's going to? I understand the importance of looking at all the patient's conditions and making a decision based upon that. And I guess operationalizing that by using these different scores and figuring out what you're going to do can be helpful. But just a comment
Sure.
about how are you handling that?
Yeah, I mean, so we're kind of similar as well, right? I say change in cardiology is as fast as molasses going uphill on a cold day, right? So we, in terms of when there are like landmark studies and there's more and more evidence pushing towards a certain therapy or treatment, like we sometimes meet as a group. So, I'm a CCU provider, and so we have our, critical care CCU, and we discuss this as a group. We say, this is what we think is important. And if it relates to interventional cardiology, sometimes I'll have individual conversations one-on-one, but when they have their, I think the time that it's ripe to be able to make some sort of change is when they have their internal meetings, and then you go and have these discussions with all at once, because one-on-one, it's always, that's one thing. But if you're able to demonstrate and show the literature and show here's what's happening, I think you have more of a chance of making some change. And then you listen to the concerns of those people who are in the room doing it and saying, I'm not going to do this or I'm going to do that. And I think that's where you are able to share the knowledge between the two to determine which way are we going forward. There will always be personal opinions and stuff, but I think as data comes out more and more, and we talk amongst ourselves, and then between our different group subspecialties within cardiology, I think that is a way to affect change. But it's it's not overnight in many cases. So that's
Thanks.
What are your thoughts about for people who have multiple stents? So, if they've had 1 stent or 2 stents with ACS, but then they have, there are people who come to clinic in stable setting, but they'll have, 5, 6, 7 stents. Mm-hmm. Are you more likely to continue their antiplatelet therapy if they've been stable on it for long term, just because of the fact that they have multiple?
Yeah, so, that's where I look at what's the risk, right? So I look at what's their thrombotic risk and what's their bleeding risk. And really for me, the major reason for stopping a P2I12 is bleeding. And the major reason for continuing it is to reduce thrombosis. So I take that into consideration. In people who have several stents, I think that there's lots and lots of a lot of thrombosis and a lot of vascular disease that you're treating, not just with a stent but with stents as well. And in fact, from the DAP study, it was the significant reduction in major adverse cardiac events were in vessels that weren't even intervened upon. So, it tells us, obviously, as we know, this is a vascular event, right? And so you're trying to reduce thrombosis all over. But I would think that that person who has multiple stents has a lot of vascular events and has a higher thrombotic risk. And consequently, there is evidence to suggest both the DAPT study for 30 months, and then with clopidogrel, and with the use of ticagrelor in the Pegasus 54 that showed, if they had an MI in the past, they benefited from like about 33 months of aspirin and ticagrelor. With the downside, I guess you could say, is the increased risk of bleeding, but minor bleeding, not fatal bleeding. And you have that conversation with the patient, and you're seeing them carefully and talking to them and making sure that they're not having any bleeding issues and stuff. But if they're doing well and they have lots of vascular disease, I definitely lean on the prolonged dual antiplatelet therapy.
Great. Well, if there are no other questions, thank you so much for your time this morning, and we really enjoyed your presentation. And thank you everyone for joining. Since it's past 8:30, I'll let everybody get to work, and don't forget to get your CME credit. And I'll see you next week.
The preceding program is copyrighted by Emory University.